Unknown caller.
And my family and I are already talking about that, and it's not easy. So to be able to go, I particularly can't wait to go back and tell my wife, because I was fast asleep. She was the one that went through that part of this. To tell her what you've done is to your absolute credit, and I'm really, really grateful. You can't put a price on it, and it's just fascinating also to hear. I mean, we know it, but to hear it is important, that it's also linked to recovery, isn't it? It's not just a nice to do, it's actually part of health and well-being of the people you're looking after. So thank you so much for listening, firstly, and then for diving into it, and fantastic. Really, really, really grateful to have heard it again this morning, and to those people who put it together, many, many congratulations.
Okay, thank you very much, Phil, and thank you for coming back to join us, because it's really helpful to close that loop on those actions and those challenges, but thank you for how you've contributed to that, so that's great. So pass back, Chair, to yourself for any questions or comments.
Thanks, and just to reiterate my views on all this, and I've met some of the people involved, and it is an absolutely remarkable service, and in some ways, like all great services, it's so obvious that you think, why on earth hadn't we done it before? But and I think the commitment to the people has been fantastic. So Donna and Keely, thanks particularly to them. I'm going to open up for some questions. I'm sure there'll be one or two questions. The question I would ask is, of course, we have in Worcestershire, although it's not always obvious, quite a diverse population across Worcestershire, and I just wondered what our experience was in dealing with that diversity of population, and how that and how we'd responded and created a family liaison service which dealt with those issues as well. Keely or Donna?
Yeah. I'm happy to come in there, actually. I think one of my other part of my role is looking after and leading on the care of people with dementia. So they have extremely diverse needs, but I think the important point is, regardless of anybody's needs, they are all the same in one aspect, but actually very individual. So with this service, as with any other service we put in for particularly those group of people, very vulnerable people, is we consider what their wishes are. So every day is a school day, really, and certainly with this project we were doing something every day to respond to the needs of that individual. So we're able to bring in diversity, but individualise that care as well.
Okay, thank you. I've got Vicky wants to come in there.
Yeah, I think it was just to ask, because when Chair, we went to visit Kelly when she was leading on this service on the Worcester site. We heard about perhaps some reticence from some clinical areas, Kelly, and I think it was how you as a service established yourself and worked with nurses on different wards, and how you resolve some of that, because as nurses we want to own the issues on the ward and we want to be in control, but as Donna said at the beginning, it's difficult because it was such a busy time. So just describe to everybody how you came through that and convinced people that actually it would be helpful to them.
Yeah, I think that's exactly right, Vicky. When we went on the wards, quite rightly, the nurses were like, "What are you doing here? We do this. What's your role? What's going on?" So there was a bit of resistance, and I think what we had to do was take a step back and just show them how we could improve and help and be involved. And one example that sticks in my mind was a quite elderly patient that was quite demanding on their time and their services, and I just took the initiative to say, well, I'll go and sit with her for 2 minutes and I'll see if I can get in touch with anybody. And once they saw that we could go and do that and go and get involved and sit and talk and work it through, we ended up then with them phoning us to come down to say, can you get in touch with this relative for us and sit and do the FaceTimes. Some of the other things that, just to touch on, is we did get involved a lot with cultural things. For example, we got Dave down from the chaplaincy a couple of times to address some needs that hadn't been met until we'd been speaking to the relatives, who actually said, well, have you seen anybody today to help with that? And we got the chaplaincy involved. We also, with one patient that was a lovely family, a big family, he hadn't been to prayer. So we managed to get his phone in, and they downloaded prayer onto his phone so that we could help him have prayer at his bedside, and that was something that just hadn't been thought of, hadn't happened. So there have been situations that we can certainly learn from.
Anita.
Thank you, Chair. I mean, first of all, just want to say what a fantastic story this is, and both, my personal congratulations to the team for having set it up, and also to Mr. Dolby for having basically instigated this. Your comments to board are what's given us the driver and the impetus to make this happen. So I think this is a fantastic success story, and really, really proud of everyone. This is patients, citizens, and the NHS working together to make things better, and I love that. I wondered whether my question is, of course, better never stops, as Matthew often says. Is there, based on your experiences, and it sounds like you've done some really innovative things with prayer and chaplains and what have you, what's next? What do you think patients might be asking for or needing? Are there other ways in which we could expand this service to be of even greater help to patients going forward?
I can come in, Donna, if you like. So one of the big things is digital. Massive thing that would help is digital. We really struggled with the amount of devices we've got, that as a trust we only had accessibility for FaceTime. It really shocked us in the beginning. Most people haven't even got a smartphone, so it was definitely overcoming some of those issues, and I think that's one area that as a trust we need to really address, is other ways. We've got the bedside tellies, why can't they act as an internet platform? There's lots of different things. The other thing is, we did a lot of work with the volunteers, with getting people to the front door. So I think, linking the two together there as well would be my ideas. I don't know whether you've got anything else, Donna.
I think you're right in what you say about the volunteers. So we're in a position now where we need to consider how we move forward, and we certainly have had valuable learning and want to take something forward. There was already a business case written by a colleague that started looking into this work some time ago. So we're hoping to take that forward, but actually I think we need to revisit what that business case looks like, and maybe think about other services that we could include in this as we step out of the urgent COVID response, and unfortunately lose the team that are going to go back to their substantive roles really, quite shortly. We're going to be going back into delivering our services as usual. We will have a standard service going on with the dementia CNSs and their team, and they do very much this job all of the time, every day. So there will be access for contacts, but we will involve our volunteers and look at how we can progress that business case very quickly.
Thank you. I've got Vicky Lewis.
Thank you, Chair. So I guess just an offer from the digital team that sit around this table to the service, if there is anything that we can help or explore with you, particularly around innovations, because we have quite a lot of people that want to come and work with us and pilot different things. So please just reach out, and we can see how we can help and support that. Okay,
I don't think I've missed. Well, thanks very much for that. It's pleasing.
Sorry, Chair.
Sorry.
We've got. I think I can see Bill's hand up.
Oh, sorry. Sorry,
Chair.
Yes. Sorry, Bill. Yes. Go on.
Lovely. Thank you, Chair. And could I add my congratulations? I think the most inspiring thing I've heard was Phil mentioning about the curative aspect of this service, and I think that's the one thing I want to make sure we hang on to. It's not just about the social niceties of life, but it actually helps patients improve. And so in terms of the business case and planning to ensure you've got the resources, both physical and emotional resources, correct, I think we've got to hang on to that thought really carefully. And if there's anything at all you think we can do to help with progressing this case, please let us know. So well done. Absolutely fantastic work.
Okay, anyone else I've missed?
Sharon, I think.
Sharon.
Why can't I see these on my thing? Okay, go on, Sharon. Sorry, I can't. You're not on.
It's okay. Thank you, Chair. I think quite a few of my questions were already answered, but I just want to say it was really heartwarming to hear that. You know, it's so special when you hear people's stories, and also the impact it has on families and what they will continue to do once they've carried on in their lives. I just wanted to know, we know after the pandemic we need to look at how we move forward, and how are we going to keep some of the good stuff that we've come out of that, particularly around the digital. Is there enough resource to do that? And if not, what is it that will be needed? And into new contacts that you would have made, just wanted to know a little bit more about how we're going to keep those people engaged in helping us to shape the things that we're doing moving forward and be supporters of the trust.
Thanks, Sharon.
So I think from my point of view, Sharon, that we've got a really enthusiastic team of volunteers, and I think it's really important, to your point, that we keep them engaged and look at actually how we can pick up some of the lessons learned through this story and get their support in taking that forward. But as Donna said, the business case and looking at actually how we can take this forward in a substantive way is absolutely essential, and blending that with volunteers and other partners is really key. So we will be, as Donna described, working with that rapidly to make sure that we get that in place, and obviously seek the digital support that Vicky's offered, and obviously Bill's support through QGC. So we will pursue that.
Okay, thank you. Thank you. Is anyone else?
Chairman, may I? It's Mark.
Yes, Mark.
Just to say, if there's anything that's required in terms of maybe pump priming for a new service going forward, then although Colin is taking over for me in charitable funds, I think there's an avenue there that may be useful to assist the trust in getting something set up. So just to put in the minds of Donna and Kelly and whomever else is taking it on, that charitable funds may be able to assist in getting this going, because this falls right into, you know, that patient experience domain that we really would like to support. Thank you, Chairman.
Okay, thanks very much. Well, an incredible story at one level, but with some dangers in it. The incredible story is that, you know, someone came to us and set out some issues. People have taken them up in the trust, you know, and they've got on and done it and delivered something, I think, which has been extraordinarily well received by our patients, which I've seen at first hand as a fantastic service for people. The issue now for us is, as we move to a different way of working in the trust hopefully post COVID, that we don't lose some of this stuff almost by accident as we move things forward, as people have to get brought back into their normal working lives. So we really do need to handle this really sensitively and well, and we don't want to lose a service by accident as we move to another one. I'm sure we won't, but I think it's worth just pointing that out. So I think we need two things. We need clearly a business case which sets out what this is going to look like in the future and how we're going to fund it and how we're going to support it. But also we need an interim plan which is going to take us from where we are now to that. We can't. We've got to make sure that we don't lose that service whilst we're moving from one to another. So really important, Vicky, and the team, that we have a really good plan which does not reduce the service available to our patients. I'd also say that as part of what we do, we really need to think very carefully about some of the lessons that we've learned through all of this. Our population, and I'm particularly thinking about population in Worcestershire, to ensure that we're learning lessons there so we can enhance a service for that particular. Obviously, Vicky and your successor will take this forward and bring it back to the board at some time in the future to enable us to make some really good decisions about what to do with this. So thanks very much. Can I particularly thank Donna and Keely for the tremendous work and enthusiasm that they brought to this work, and thanks to Phil for giving us the push in the first place to make sure we did something worthwhile for our patients. So thank you very much for all of that. Okay, let's move on then to the board meeting, which I got in the wrong order. But just to go back, we've approved the minutes of the last meeting. They're a reasonable reflection, we think. Yes. And then can we go on to the action log? Rebecca, anything on the action log we need to understand?
All actions have been completed on the log, and we'll pick up anything from this meeting into the next session.
Okay, thank you very much for that, Rebecca. Let's then move on to my report. I'll be very brief. Clearly, in the declarations of interest, I identified that I was taking on the responsibility of chairing the Sandwell and West Birmingham Trust from the 1st of May. I'm very much looking forward to that, but that will not mean a diminution or a lack of engagement in what's happening in Worcester. I will continue to be the chair of the trust and put as much effort as I normally do to make this a success. So I'm pleased to announce that Anita Day is going to be the vice chair of the board going forward. She'll make a fantastic contribution, I know, and keep me in order when I need to be kept in order. And we're looking forward to working with Anita in that field. And in terms of Mark, also chaired, I'd like to say that Julie Moore has agreed to take on the chair of the People and Culture Committee. It's a particularly important time, I think, for the Trust in terms of the learning that we can have from our patient survey, the challenges that we've got in terms of workforce planning going forward, and the important work we need to do to embed the culture of improvement in our organisation as we go forward. I've started the process in terms of the appointment of a senior independent director for the board. I've asked for people to put themselves forward or nominate people. I'm going to go through that process, and then I'll bring to the board at the earliest opportunity some proposals for the appointment of a senior independent director. Okay, thank you very much. Let's then move on to the next item on the agenda, which is the Chief Executive's report. Matthew.
Thank you, Chair. Good morning, everybody. Fantastic patient story, and I just want to echo your words, Chair, to thank Mark, and looking forward to working, Mark, with you in your new role. But I also, in addition to a couple of comments that I'll make on my paper, I just want to take a moment to recognise the fantastic work of Vicky Morris, my favourite chief nurse. I mean, Vicky has led the strategic and the very detailed quality improvement work with the executive team over the last few years. I know that she's highly respected by her nursing team and her nursing leaders, but also by the doctors, which is no mean feat, and by other members of the senior leadership team and the ward-based teams as well. I'm particularly pleased as well that we have Kelly Bill on the patient story, because Kelly is a healthcare scientist, and one of the things that Vicky's done brilliantly is to bring the voice of therapists and healthcare scientists and non-nurses in her non-nursing leadership role for the board through to being much more prominent and much more valued. I hope a sense of being valued within the organisation. So for me, that's been a really important contribution that Vicky's made. And I also want to thank Vicky for staying on and delaying her retirement. I'm not sure whether all board members know this, but when COVID hit, Vicky came to say that now's not the right time for me to retire. I'd like to stay on a bit longer to make sure that I can support colleagues and professionally lead the nursing staff of the organisation through the COVID pandemic. And I know there's a little hint in her mind that COVID's not quite finished yet, but I know that she is looking forward to handing over to Paula Gardner when Paula joins us on Monday for that two-week period. And I know also I can speak on behalf of the executive team. I mean, Vicky has been the glue that's kept people together. If there's ever a slight gap in needing to cover things, I know from Paul's perspective, and Mike's perspective, and Tina's perspective, Vicky's often stepped into the breach to make sure that things are done. And one of the things I think as an executive team we will need to reflect is how do we replace Vicky Morris in everything that she has done, both visible and invisible, and the support that Vicky you've given to me over my 2 years here, and I know to my predecessor has been immense, and I want to thank you publicly for everything that you've done. I wish you a happy retirement and happy lambing season. Just moving on to a couple of points in my report, not to steal people's thunder. Obviously, the CQC maternity report will come up later, as will an update around COVID. The vaccination progress has been fantastic across the county, and I suspect we'll be touching on that later in the meeting in terms of the numbers of our staff that have been vaccinated. But of the population of Worcestershire earlier this week, we vaccinated 51% of the eligible population of the county, which is fantastic news. Just draw attention also to the webinar that our BAME network hosted to support the colleagues perhaps across the organisation that have had some hesitancy around the COVID vaccination, and a note of thanks particularly to Salim Shafiq, one of our consultant haematologists, who himself is shielding, who put a huge amount of effort and work into the preparation for the webinar. I wrote to him earlier this week to thank him and mention that I would mention in dispatches. Another thing, Chair, if I may, just to note two other things. The NHS Improvement is planning to review our progress at their Provider Oversight Committee in April, since we were taking out some special measures, and our teams have been helping the regional team to provide a narrative around the progress that we made prior to COVID and through COVID. So I'll be reporting back on that in due course, probably at the next meeting. And then finally drawing together, I think, some of the strands that we covered in one of the papers, short, and the reference to the integrated performance report. I think one of the things that we as a board will, I know, want to understand is how has the COVID impact on the organisation from an operational day-to-day perspective reduces, and how and when people return to their substantive roles who have been redeployed and focused on COVID operational and quality issues, how we can make that step change back in a range of indicators on our performance dashboard back to where we were, and then continue to improve after the last year. Because one of the things that I'm very clear on is things such as our ambulance handover delay progress needs to continue to completely eradicate it. Our progress around mandatory training and supporting our workforce, our progress around sepsis, our progress around infection control, all of those things are absolutely essential for us to progress our improvement work. Because I think I need to coin my phrase, well used and slightly tedious now, but I think that my focus into the organisation is very much, we continue to improve because better never stops. We of course need to make sure that our workforce is supported through that. But I think one of the things that over the course of the next couple of meetings, I do think we now need to focus on how do we now start to really address some of the quality performance and financial aspects of our performance as an organisation. So I'll pause there, Chair. Happy to take any questions.
Thank you. Any questions? Comments? Wakar.
Thank you, Chair. I just wanted to congratulate Matthew on the not just the letter that's received from Dale Bywater, but also the BAME network. I attended the seminar and I thought it was brilliant. And it's something that we should do more in terms of engagement with our staff. And particularly in light of the low uptake of the vaccine by BAME staff, I just wonder, I mean, consent is very important, but I just wonder, you know, what more we could do. And secondly, whether from this board we can perhaps take the message to the wider system, you know, in terms of their engagement with the black and minority ethnic communities, particularly in Worcester, Redditch, Kidderminster, elsewhere, Bromsgrove, that they do, you know, step up the pace of engagement, you know, particularly around creating community champions, engaging faith leaders, you know, as well as we have done here at Worcestershire CUDE, perhaps large employers like, you know, the county council and the local authorities, perhaps holding seminars with black and minority ethnic group, because the situation with the various minority groups in this country hasn't changed, although there's been a number of campaigns running. So we do need to build that trust and confidence and raise awareness.
Thanks, Rocco. Really good points there. Matthew.
Yeah, thanks, Chair. Thanks, Rocco. I think you're absolutely right, and to provide some assurance that the STP system Gold Command meetings that happen now on a weekly basis. They were twice weekly, now weekly. This discussion has been had certainly over the last 2 weeks. With how to engage, as you say, faith leaders and other community leaders to try to make sure that we're, rather than perhaps using you know, one size fits all type approaches, that actually we try through the council, through the public health teams, particular different approaches, as you say, to supporting and getting the conversation going into some of those communities that you describe, and I think there is an active drive to do that. I mean, one of the things that we've been discussing as an executive team really over the last few days is how do we make sure we get the balance right, as you say, between not being overbearing and forcing the issue, but really understanding what is underneath the reticence and the reluctance to step forward, and finding ways to try to address that. And as you know, that was part of our thinking around the webinar. And I think part of the next step for us is, yes, we're going to talk with our staff side representatives and colleagues about how do we walk the path with our staff representatives, just to help to move this forward further. Because I think the right approach is making sure that we've got forward advocates, we've got our staff side representatives, we've got our chaplaincy team, all of that working together to try to help our colleagues to do the right thing, but also just to understand some of the issues, because some of the issues that are impacting on COVID vaccine practice may actually be engagement issues for us generally that we need to get under the skin of, really properly understand. So I take your points on board, and it very much is something we're focusing on.
Okay, thank you. Any other questions in relation to that? Tina.
Just if I can just add a bit more. So we have contacted, there's about 1,100 members of staff that have yet to take up the COVID vaccine, just to get some feedback of why there might be some reticence to do so. And the main themes so far are concerns around impact on fertility. So people that are either trying to get pregnant or are pregnant. And there are also some religion as well, that people, it's against their religion or feel that they don't need a vaccine. So to Rakar's point, I think the connection with the faith leaders is really important here, in which we are reaching out. And for me, the importance of the internal advocates from those faiths to then provide that link is something that I think is key for the next steps. So I'll obviously keep you posted on that. Our current compliance for BAME colleagues is 74%. So we've got about just over 300 colleagues with a BAME background that haven't yet taken up the vaccine that we're working with at the moment.
Okay. I mean, this individual connections, these individual conversations are really important. It's interesting looking at some data from some other parts of the country. When they've done the one-to-one connections, is that they found about a third of the people they've contacted actually have had the vaccine. That actually still we're not quite right on the the data is still a complexity because of the different places people can go to it. About a third of them just hadn't got round to it and were susceptible to a conversation. So that that third is a good place to go, and a third basically were implacably opposed because of religious or other things, which is obviously more difficult. I don't know. I don't know whether other people can tell me whether there are many religions who say that vaccination is simply not allowed. But that's why it's so important for us to engage properly with faith leaders and other people across Worcestershire to make sure that we're well connected in all that. And I have to say, some of our own staff have been fantastic in this, doing videos from Worcestershire to encourage people to be vaccinated. Great leadership from a whole range of our ethnic and minority staff. Okay, well, thanks for that, Matthew. Let's then move on to the next item, which is the COVID-19 update. Paul.
Thanks, Chairman. So at the time of writing this report, it was the 27th of February in order to get out for the board. I think the general headlines of the report are the number of cases reducing, discharges holding, and the level of beds allocated on COVID pathways reducing, little change in length of stay or mortality. In giving you kind of the latest news in an update of where we are since writing the report, we have seen the number of COVID cases reduce to hit a low on the 6th of March of 70 across our 2 hospital sites. We've also seen a reduction in the number of clinically suspected but not confirmed cases, and the number of fatalities have reduced significantly, running now between one to two a day. So that's positive. The Trust has also seen a reduction in the rolling 7-day average of new cases, and was seeing an increase in the rolling 7-day average of discharges. But the discharge numbers have now slowed down, and just a kind of word of warning that since the 6th of March we've seen a day-by-day slight increase in the number of COVID positive patients within our hospital, and as at this morning that number has grown to 81. So although the numbers are much lower than our peak on the 21st of January of 269, I think this just demonstrates the need to maintain all the safety precautions that we've put in place, maintain the continuous testing of patients, both as they present and then whilst they're with us as an inpatient. And I think it also indicates that slight level of volatility between community prevalence, which has consistently reduced and now stands at 82 per 100,000 population for the county. It does indicate that we're still seeing a all but gradual increase in patients presenting. On the positive side, we set a number of triggers, and even at 81 today, that still sets that trigger where we would, as a system and as a trust, move from alert level 5 to alert level 4, and that was reached on Tuesday, and Gold Command on Tuesday moved us to alert level 4. What should be noted is all those triggers, which were around the number of beds that are allocated on COVID pathways, community prevalence, number of patients in our hospital that are COVID positive, and a balance between the rolling 7-day average of new versus the 7-day average of discharges. That they were all acute based indicators or triggers, and although we have as I said, achieved that and moved to alert level 4, we're very clear before we would consider any further de-escalation, going from alert level 4 to alert level 3, we would expect a broader range of system indicators which reflect flow and discharge both to the normal place of residence and access to community beds to apply. So I think at this stage I would say cautiously positive, but I think that we shouldn't lose sight of the challenge that we've faced during this pandemic, and although we have moved to alert level 4, that is still a high level that requires a range of actions to be operational in order to maintain a safe environment for both our patients and our staff. And just to give you some context, with our number of cases, positive cases, sitting at 81 this morning, that puts us the 5th highest number of positive cases within the region. And there is really only the tertiary centres, which are clearly bigger hospitals, that have more positive patients than us. So I think my kind of headline would be numbers are reducing, but there is a volatility there. We need to maintain our focus and make sure that the environment that we are operating in is as safe as possible for our staff and our patients. And key to that is maintaining regular testing for both staff and patients, so that we preferably negate any sort of outbreak. Thank you, Chairman.
Thanks very much. Thank you, Paul. As usual, a very comprehensive report. But clearly, there are, even in the conversation we've just had, still more than 10% of our beds are full of patients with COVID, so it's really still significantly impacting on services. What I couldn't understand from it, Paul, is to what extent the increase was because of problems of discharge rather than anything else, because the number of patients you have in any one time is a consequence of admissions and discharges balancing or uncharged problem here that's making the numbers look bigger, or is it a volume of illness?
The discharges have slowed down, but the volume of new patients has, over the last 7 days, for example, has been roughly maintained. So if you take the last 7 days, then the number of new COVID cases is 38, and if you look at the last 7 days of discharges, that's 35, and with deaths reducing to 0 or 1, that's why we've seen the increase in the number of cases.
Yeah, the only point on the discharges, is it because people are ready to be discharged but can't be discharged, or is it they're just not ready for discharge? Just so I understand that.
In relation to the COVID positive patients, yeah, I would put it at about 90%, 10%. 90% are too poorly, 10% delayed in discharge.
Okay, let's move on. Mark, I've got Mark next.
Thank you, Chair. Paul, again, good report, which is very explanatory, and thank you very much. There's 2 points hopefully you could expand on. I'm aware that you and the teams are putting a huge amount of effort around infection prevention and control, but can you give us any sort of comparative information with regard to how we are doing with hospital-acquired COVID versus comparators? And the second one is around non-symptomatic. Obviously, within the paper there, it shows the amount of non-symptomatic positive tests. So just to ensure I understand, does that mean then that we could easily have non-symptomatic deaths which show on the COVID figures because they have had a positive test within the last 28 days? Thank you, Chair.
Okay, I think Vicky's trying to come in there to answer some of that. Is that right, Vicky?
Yeah, if I could, because I think this morning I've had a meeting with the regional chief nurse in terms of outbreaks, and as Paul has described, as the prevalence goes down across the community, then there is a more focused attention on any outbreaks within the hospitals. But I'm very pleased to say that our informatics team, who've been fantastic during COVID, have provided some really good source of information, both in terms of the hospital acquired and how we track that, and reassurance and assurance for them that we've got some rigorous processes internally to be able to identify both the points that Mark, you've said, which is obviously hospital acquired to the national determinants for that, and also then associated deaths in relation to COVID, including up to 30 days. So I think that the informatics process, the rigour through the command and control, has supported the controls and measures that we needed to have in place, including obviously the swabbing of patients as soon as they enter our ED.
Okay, just I mean, in terms of benchmarking, are we a particular outlier in terms of
that was
hospital-acquired COVID, or are we doing well, or how?
That was equally part of the discussion, because we were discouraged from benchmarking with the regional data, although it is available. However, this conversation arose because some of our figures were obviously, in comparison with others, had for a short period of time had gone up, and hence the conversation. So what they are looking to do nationally is to encourage the safety team, and there was a call today nationally to get the comparators very similar to the C. diff control figures, so that you look at a rolling data per 100,000 population, and that was found to be the more reasonable way to benchmark and look at our own improvements internally, as well as a view by national and regional teams. So there will be some improvements to how we do that benchmarking.
Okay, so are we worried? Are we an outlier in all of this at the moment?
No, we're not. In terms of regional figures, from our outbreaks, we've only got now 6 today outbreaks, and we had 7 yesterday. One's closed today. So in terms of the figures, the regional team were assured in terms of where we sit at the moment.
Okay, fine, thanks. I've got Sharon next.
Sorry, Chairman, do you just want me to answer Mark's second question?
Oh, sorry. Yes, go on then. Yeah.
So the answer is yes, Mark. In terms of we would if the patient is COVID positive and by PCR, and is then subsequently dies in hospital within 28 days of that swab, then that patient would have recorded on the death notification form that the patient was COVID positive.
Okay. Can we move on then to Sharon?
Thank you, Chair. Paul, thanks for the report. It's really comprehensive. And it's just a question about the COVID remissions. I was just curious as to whether we know the reasons behind that. Is that because maybe we think that they might have been released a little bit too early, or is it because of the deterioration in their health that's pulled them back in? So I was just curious around that point.
From the work that we've done, Sharon, the readmissions are almost exclusively deterioration rather than inappropriate discharge, and we haven't picked up anything around that. There is sometimes when patients are discharged to the community hospital, and the community hospital then after discharge have found some challenges in maintaining and managing those patients. They've been readmitted, but the readmission is, I would say, 99% deterioration, not inappropriate discharge.
Okay, thanks. Richard?
Thanks, David. So one of my two questions was actually the same as Sharon, so that's been answered. The other one, Paul, I completely understand, first of all, the concern that we still got given the current situation. But I thought there was some encouraging news in the report also in terms of the shift in age groups, which to me kind of is maybe the first piece of evidence that the vaccination is working. But then I was a bit surprised by the difference in the older age groups and the one between 65 and 74, where we didn't see the same effect. Is there any explanation for that?
Sorry, Richard, no, I don't have that. On the younger age groups, there is a very clear link, as we're seeing the increase in the community prevalence, where the increases have been, is in the lower age group, and it's diminished significantly in the over 60s. But I can't give a reason for that middle age group that you referred to, Richard. I don't know the answer to that.
Okay. Well, perhaps someone could give us a bit of help on all of that.
Yeah, I'll have a look, Paul.
Thanks. Thanks. Okay. I did have Bill, but he's disappeared. You don't. You're all right, Bill. Okay. Okay. Wakar.
Thank you, Chair. Paul, can I join my other colleagues in complimenting you on your comprehensive report? My question relates to the mortality, the crude mortality rate. I mean, I'm 2 months old on this board, but the reports that I have looked at, they're consistent. I mean, you see between different hospitals, you should see, I mean, there are other people who are experts in this area on this board, but you should see difference, on a month basis between hospitals in terms of crude mortality rate. But with Alex, it's consistently higher. So whichever month that I've looked at, it is consistently higher than the Worcestershire Royal. Have we done any work, any analysis as to what is going on and why is it? I mean, I would expect sometimes, perhaps Worcestershire Royal to be, to be high and perhaps Reddish to be lower, but Alex is consistently, and I don't know what's going on, and have we done any analysis as to what is going on, why these rates are higher in that particular hospital?
I mean, Bill may want to come in. I think he's got his hand up, but if I can just give you an initial overview. So the overall crude mortality rate for the trust for patients is for the whole period since the very beginning of the pandemic in March last year is running at about 29%, which is just below the kind of national average in the 30%, and that split. The Alex is running at about 33.5% crude mortality rate, and Worcester at about 25.5%. Vicky, Mike Hallisey and myself review the death notification forms which relate to every patient who has unfortunately died with a COVID, I would say with a COVID diagnosis, and we have not found any indication of any deaths that would give us concern based on the comorbidities and the presenting complaints between both hospitals. I would also say that the level of prevalence has been particularly high in the Bromsgrove Redditch area, and was throughout the second wave was outstripping the rest of Worcestershire, except on a middle block occasion in January when Worcester City prevalence was high, but the Bromsgrove Redditch and community prevalence per 100,000 has been high throughout the second wave, and higher for the over 60 group.
Okay, Bill.
Thank you, Chair. It was really to try and help answer that question, Wakar. So I think one of the issues is that we're looking at crude mortality rates, and those are not being controlled for age, comorbidities, any other aspects. And it's likely that the populations that each hospital serves are subtly different in those regards, particularly around the influence of urban travel and work within the Birmingham conurbation. So from a clinician's point of view, I'm not concerned that we're seeing a systematic problem in care delivery at the Alex. I think this is much more likely to reflect the population dynamics of the hospitals, the differences between those two. When and as we have no longer just got crude mortality rates, we'll be able to look at that in more detail. In other aspects of measurement of mortality, the two hospitals generally have an inverse proportion of mortality rates, so that the Worcester mortality rate is marginally higher than the Alex. And I think that again reflects the sorts of services that we offer in both of those hospitals. So we are keeping a close eye on mortality from the quality governance perspective, and I will absolutely pay close attention to that in the months ahead to make sure we're not missing a healthcare effect between the two hospitals.
Okay, thanks. I've got Anita, and then I've got Matthew, who hopefully will kind of sum this up, and we can move on to the next item. Anita.
Thank you, Chair. Again, thanks, Paul, for a good report. I just wondered whether we were at this stage having any significant impact from so-called long COVID. I mean, we've talked about readmissions, but I'm assuming that's within 28 days or something like that. But are we starting to get, particularly from first wave long COVID, and is that starting to have any impact on our ability to deliver services? Thanks.
We're not finding that prevalence within the hospital at all, Nita. But that's as at now. So no, is the straight answer.
Yeah, thanks, Chair. So just coming in on a couple of the points. I mean, I think. Anita, I think your point about long COVID is certainly something that Mike Sott's on leave, working with GPs and others to make sure that the community-based response means that those patients don't end up coming into hospital, that actually the post-viral syndrome symptoms are managed certainly in community settings. Although I think we touched on before the impact on lung fibrosis impact will be something our respiratory team will be working very closely with primary care in helping to manage that impact. I think really good conversation. I think a couple of points I would just draw out in addition to Paul's emphasis in the paper. I think one of the things that we want to get under the detail of and make sure that is represented in this report, which I think will be hopefully in the next few board meetings, will show that continuing reduction, albeit that we've got a plateau at the moment, is the ethnicity picture as well as the age profile for the patients that have been treated, and that needs to be certainly added into the report. I think the report also needs to include where we are in terms of vaccination, so that's something that we'll work on, so that we've got a catch-all, if you like, of some of those indicators. I mean, one of the things that occurred to me, again, going back to my earlier comment about returning to business as usual, is that as we get back into business as usual for our mortality reviews, so our reviews of deaths in hospital, our intention is to get back to reviewing yesterday's deaths today with our medical examiners. Some of the questions that we're asking ourselves about whether there is any concern with a higher mortality rate at the Alex compared to the Worcester, or the other way around, as Bill's already alluded to. We'll get that immediate data from the medical examiners and the learning and changes in practice that might need to come about from that. So that's one of the things I'm keen that we can get ourselves into good position as quickly as we can, so that we can turn the learning from our care into improvement, which I think is the key piece for us. And Chair, if I may just to sum up once again, thanks to Paul and the team that have been leading our incident responses. There's too many people to mention, but of course we do have our big targeted Thank You Thursday event on March the 18th, which is the anniversary, for want of a better word, of the first COVID patient being admitted into our take the opportunity to pay tribute to everybody that's done such a fantastic job, whilst recognising that we want to make sure that, as Vicky's alluded to and Paul's alluded to, that we continue to manage the patients in the best possible way and support our staff in the best possible way.
Okay, thanks for all that. I mean, just to add my point in all of this, I think we're assured that, you know, that we managed it very effectively over the period, and all credit to, you know, the clinical leaders, the managerial leaders, and also the frontline people who've done the work. It's been a remarkable sort of teamwork to enable that over yet, and there's still a lot of work to do to make it a reality. But I think we can be assured that things have gone pretty well as far as this trust is concerned. And thanks for everybody, Matthew and your team, for the work that they've done. The issues around mortality are always significant. We've spent quite a bit of time as a board thinking about mortality, and under Bill's leadership, the Quality Governance Committee will continue to monitor the mortality in the organisation as a whole, to ensure that we're doing everything that we can for our patients. So thank you for that. Let's move on then to the ICS and Trust Action Plan. Jo.
Good morning, thank you, Chair. So hopefully everybody's had a chance to read the paper, and this is the white paper that's come out since we last met as a board. So what I propose to do is just draw out a couple of points that I think are worthy of note for board colleagues, and then just pick up in terms of actually how we're proposing to address some of those. First off is just say there is a legislative basis now for the work that the ICSs are doing, and one of the key changes will be that CCGs will cease to exist. So I think that's one of the bits that's been confirmed through the white paper, but also giving us quite a permissive approach to how we work through the activity. We have been identified as one of 7 nationally ICSs, and I think that both enables us to shape how ICSs develop, but also it is interesting just to see how much further thinking considerations need to be undertaken to iron out some of the areas that have been identified in the white paper. So just moving through in terms of the issues and options, designation will be from April, and we will be in a shadow running year then as we try and set up these 2 separate entities, the statutory NHS body, the details of which you can see in the paper, and the partnership board. And there's lots of debate about how that fits with Health and Wellbeing Board locally, as you can imagine. It's interesting to see what's focused on and what is in terms of detail, and you'll see that running through the rest of the report. So clinical leadership, we've identified duty to collaborate, and also to flesh out actually the differences between the statutory requirement of us as a trust and an organisation and how that fits with the wider body, which are clearly elements we'll need to work through. But key to this is just the emphasis again that actually place, i.e. Worcestershire, is going to be the real key driver in terms of the activities done with powers delegated to it from the ICS Herefordshire and Worcestershire body.
Sorry, sorry, David, can you mute your microphone? I hear a strong echo. I don't know if the others hear it. Thank you.
Just moving forward then, the other bit to note, we've rehearsed before the change in competition and the provider purchaser split, and it's interesting they have recognised that actually we can't just remove tariff totally, because we need to use it as part of a sort of mechanism in terms of managing and overseeing the contracts and performance, but we're still yet to find out actually what it means in terms of what the financial framework is. And you'll also note that there are powers now being moved towards the Secretary of State, which is a change from what we've had over the last few years. So the rest of the paper just rehearses the widest determinants of health, emphasises the change to data sharing, which again is a key enabler to really help us move forward as a system as our patients navigate through that, and also just references the social care element, which I think there are views that could have been more transformational, but there may be some more work coming through on that in the future. And on the final page then, you can see that the ICS Exec Forum have identified the key areas that they want to move through with, and obviously we're a key player to help support that. But I just wanted to add in terms of the list on there, because we're taking responsibility for moving forward with the planned care theme, which, if you recall, is in our 8-point action plan. And there's been some really healthy discussion over the last week or so about how we have both the recovery element of that, which is obviously returning to the elective services, but also the transformational side in terms of developing the programme of work. And finally, Chair, since the paper was issued, there has been a move to actually say we need to accelerate development of the place board element of this. So this would be bringing together the AEDB and the Worcestershire Alliance Board, and we're trying to move to getting to that point sometime in the early summer, around July. So this is all supported by the 8-point action plan we discussed at the last board. It doesn't change the focus of that, and now we're into recovery phase. We're standing up meetings with all the leads to follow through on the detail of the action plans. I'll just ask the board to note the report, Chair, and if there are any questions, obviously happy to take those or refer to others who are involved in the ICS Exec Forum.
You're on mute.
There you go. I'm not convinced I was responsible for the echoing, but go on, Richard. But that's my excuse for not. Anyway. So, an important set of changes for the NHS overall. I think I was counting out the other day because I got nothing better to do. I think it's the 22nd reorganisation I've kind of been subject to since my beginning of my career in the mid-70s in the NHS. But some important changes there. I mean, one area you didn't cover, Joe, was the issue of provider collaboratives. And in a sense, what are we going to do as an organisation in terms of working with other providers, which I think, from our perspective, is something we need to give a bit more thought to. But anyway, let's open it up for questions then as we go along. Sorry, do you want to come back straight away to that, Joe?
Well, just to say, if you recall, that was one of the 8 action points we had in our own first action plan. But I think you're right to flag it, because in the discussions we have with the system, I am continually trying to remind them about the need for us to get into that element as well. So.
Yeah, I guess the system are less interested in that because it could go outside the system, couldn't it? Anyway, but that's another story entirely. Let's move on then. I've got Mark and Colin so far. Mark.
Thank you, Chair. Thank you, Joe, for the paper, which I think quite succinctly captured sort of more the main elements of what the white paper is showing. And it was just to make the point that items 1 to 6 are going to be really fast moving now, because the ICS as a statutory body or function should be in place working for 12 months from now. So everything needs to be sorted pretty rapidly. And can I ask that you keep board pretty tightly involved in the discussions about how it is moving forward, because and it might even be outside of board cycles, because it could move, within month. And it was just a plea really to try and ensure that board is kept involved to the best you possibly can. Thank you, Chairman.
Okay, Colin.
Thanks, Chairman. Really helpful paper, Joe. What's going through my mind is that I guess we'll be presented with a bit of a challenge in terms of ensuring our enabling strategies are consistent and parallel with the strategies of the ICS as when they develop. And I was thinking in particular of the digital strategy. So do you think we will have to revisit and restate those strategies in fairly short order?
Yeah, can I ask Vicky to say something about that? Because I know she's been working on the digital strategy across the system as well. Vicky.
Thank you, Chair. Thank you, Colin. Yes, we have got a consolidated view of the digital strategy at the ICS level, and we are also helping support building some of the architecture that's required for those data sharing agreements to exist. I don't know if colleagues will recall, but we've spoken previously about the integrated care record architecture that's going to link all of the statutory organisations together, and also allow for those new emerging clinical models of care, which will no doubt follow as part of this ICS work. So we have got a weather eye on it, Colin, and are working towards that. We've got a well-established digital board also at the ICS level that includes technical design authority as part of that configuration. So hopefully we'll have picked up all the bits that we need to. Thank you. Thanks, Chair.
I think part of the issue here is that we have to get into our heads what the ICS is, i.e. it's us. You know, it's not another tier that's been put above us. It's actually us working together with other organisations. And there shouldn't be a position whereby the ICS has a set of policies or procedures which are different to ours, because we should be building them with them. But that's not to say it won't happen. You know, that's not to say, and we need to be really clear about all of that. But if we play our full part in this, we'll make sure that everything is consistent, and in fact they will work together to make things even better. Okay, any other points before Joe, you want to finally say anything about all that?
Yeah, just to first of all, just to thank Mark, because I know he's been representing us on the ICS exec from a non-exec perspective, and I think that has been really useful. And his point about actually how things accelerate is really well made, because, you know, with everything else going on around us and trying to restore our services, you know, the ICS is still motoring on. We have got good collaboration and alignment, and there's a lot of the exec directors on the gallery, well, most of us in fact, are involved in those system discussions. I would suggest, Chair, that the ICS action plan would take regular updates through F&P, just so you can sort of have oversight in terms of how that's progressing.
Yeah, my view on that is probably we need to take something at the board regularly, have a regular slot, so that in her role as Vice Chair, Anita will be taking her place on the ICS executive board, and of course the work that you're leading across the system as a whole, Joe. If we could have a section on the board basically bringing in to make sure that everyone is kind of brought up to the same level, I think that would help us. It doesn't have to be a massive thing, but I do think that everyone needs to be brought up to date as we go along, and that would be a way of cementing that in. Is that okay? Good. Okay, well, that's fine. Thank you very much. We note that, and we endorse the outline in relation to the ICS Executive Forum. Can I move on then to annual planning, restoration, and medium-term financial strategy? Joe, I think you're going to lead this piece of work.
Yeah, so I'm going to introduce it. Thank you, Chair. But it's very much a three-part paper, really trying to draw together where we are in the overview of how we're planning to deal with the complexity of the annual planning process this year, how that then leads into the restoration of services, and then a commentary just around the medium-term financial plan and the wider clinical services strategy. So I'll draw in Paul and Robert at appropriate points, if that's all right. So again, hopefully you've had the opportunity to read the paper, and we've rehearsed before that there have been national changes that mean that the guidance is not yet issued for next year, so there's a rollover for Q1 period. And you'll also be aware that locally, because of the level 5 situation, we've not been able to progress since we brought the paper to the board last November. So we've been doing a lot of background work. The annual planning steering group has still been meeting, and we've had to do some top-down approaches to things like some of the financial positions as part of a regional return that was made at the end of January. So where we are now is we're very much wanting to bring back together, and we've been meeting with the divisions this week and over the next couple of weeks to join the bottom-up part to that work, because the bit we've not been able to do yet is the triangulation with some of the finance run rates with workforce and demand activity. So we are just restating and rechecking some of the underlying assumptions pending any guidance that comes out from the centre. So the detail of that is in the paper, including for Q2 some of the financial framework that's our current understanding. So that involves a continuation of the system envelope, making sure that we're consistent with long-term plan priorities and actually where the CCG, as part of the restoration planning, is going. We've been having active discussions with that, recognising there's a blended payment approach as a default mechanism, particularly affecting our secondary care services, which is outlined in a paper, a document from 26th November, and that we're anticipating there may be some other funding for elective recovery, but we'll need to assess the implications when the next plan guidance comes out. And then again, the capital funding, we are anticipating a similar method of allocation. I'm sure Robert might want to pick up on that at a later point in the discussion. So we're just doing a stock take a moment in terms of where we are in terms of business cases, from a PEP perspective, doing first cut of the activity data, and we're got just this next week some divisional finance reviews to understand particularly what that budget position is, because we do need to do budget setting for the start of the next financial year. So I'm going to suggest then, as we move into thinking about how we're restoring services, Robert, do you want to come in first, and then we'll hand
I was going to let you finish, Joe, and then I would just contribute on the money side, if that's okay.
Okay. Well, I was just going to move on, in fact, to talk about actually. So it outlines the restart of the services we've got, but I just wanted to move to how we plan to do the recovery plan, and we've had it working with the STP. They've developed a draft STP recovery plan. So we're looking at how that aligns with clinical services strategy and actually how that fits in terms of the elective work stand-up. And I was going to actually invite Paul to discuss that. So Robert, your call. Do you want to come in now, or do you want to hand to Paul?
Probably makes more sense to hand to Paul first, and then I'll contribute. Thank you.
Yeah.
Paul. Thanks, Joe. Thanks, Chairman. So, in terms of the work programme that we've now got in place, there's clearly the internal work and that associated with primary care colleagues. So we've done as we said we will do in terms of completing the work at A-Block at Kidderminster and relocating the chemotherapy unit out, and we remain on plan for the for mid-April to have all 4 theatres fully operational, at the moment 5 days a week at Kidderminster. We have started the decommissioning of some of the wards at the Alex so that they can be cleaned over the weekend. So Ward 18 will be empty by tomorrow, will be cleaned over the weekend, and will come back in as a purple pathway on Monday. And we've got agreed theatre schedule list now for the next 4 weeks that will start to restart that elective work at the Alex. We're then planning to extend throughout April and May the capacity on that site, so that wards 14, 17, 18, sorry, 14, 16, 17 and 18 will become fully operational as 103 beds for elective complex surgery and elements of routine surgery. And we're also bringing online what was the old wards 9 and 10 as a multi-specialty day unit. So the plan is to concentrate elective work at the Alex in the multi-specialty day unit and the 103 beds that we're kind of converting to elective from either COVID or non-COVID but emergency, and the 4 theatres at Kidderminster. So that will be the phase 1 of the scheme that will run in Q1, and then phase 2 for Q2 onwards is assessing the potential to operate those 10 theatres, the 6 at the Alex and 4 at Kidderminster, on a 6-day basis. The bed and multi-specialty day unit will have the existing capacity to cope with that. The issue will be, the biggest challenge in all of this will actually be workforce related, as we are challenged in particularly in theatre nursing staff. So that is an area of real focus, and without increasing our recruitment in that area, we will not be in a position to go from 5-day to 6-day operating. To be clear, in terms of the bed-based capacity, that's already in our baseline, so it's the prioritisation and use of that bed-based capacity. It is not about an increase in the bed-based capacity and therefore the inpatient cost base. So that's the plan at the moment. We're also working closely with our primary care colleagues around handling the patients that are currently being referred but not seen in the period March to October 2020. Clinical colleagues both in the trust and primary care are confident that since we rolled out the advice and guidance service in full in October last year, those patients that have been referred in, we're clear on the patient's condition and management of those. It's the patients that were referred but not seen in the March to October period before the advice and guidance came in. So that's our number one priority, and we're just working through the restoration form and oversight groups have both been reset up, and we expect to work through opening up at further outpatient and ambulatory capacity on the Alex and the Worcester site over the next 14 days.
Robert, do you want to come in?
Yeah, okay. Yeah, just building on Paul's setting out there, one of the critical things for us obviously is how we use the resources that we've got within and the capacity constraints that we've got, because we've got to make sure as we increase the activity, and as we can see from the later on in the IPR, it's clear that while we're using theatre time, we don't have the throughput under COVID that we had previously, and we know that the critical thing we've got to do is be reducing our average cost per activity, and that's one of the things that the trust has got the biggest challenge on. So I think it's about how we increase the work, but actually do that in the most efficient and effective way. And that clearly is very much as Paul's outlined, you know, the theatre sessions and the outpatients by specialty. So in terms of nationally, as we know, we're not clear what's going to be happening in terms of the income. So for us as an organisation and working with the system as well, the critical thing for me is actually how we manage the cost base and the expenditure going forward. So at the minute, what we are doing in the simplest terms, as the paper says, is the initial financial plan is very much about the cost base built on the 2021 financial plan, but adjusted for agreed business cases and inflationary increases. And what we need to do is that further work around the level of activity that we can undertake in the next few months, particularly looking at that the impact of COVID. So challenging, but you know, we know what we're doing in terms of setting, I think, that initial baseline. But we're working, as Joe said, with all of the divisions this week and next week to make sure we triangulate the funded capacity and the activity projections which need the work. Muted, David.
It's me again. So I've got hands up already, Joe. Do you want to say anything finally, Joe, or shall I get on to questions and then you can kind of come together at the end?
Yeah, I think if we take questions and then we can sort of do that bit looking to the future at the end. Yeah, thank you.
Okay, I've got Bill next.
Thank you, Chair, and thank you all for your comments. From my perspective, I'm struggling to understand where restoration ends and where recovery begins, in that the magnitude, my anticipated magnitude of the work that needs to be done to reduce our waiting list is enormous. So I just wondered, Paul, with the 10 theatres working on a 6-day programme, how rapidly do we start to see our waiting lists fall? And as a consequence, have we got an ambitious enough plan to meet that demand? And as a second part of that, If not, then what other opportunities do we have to increase both diagnostics and theatre activity?
Thanks, Bill. Paul, Richard, are you on the same sort of lines in your question, Richard?
Well, this was one element of it, so let's get an answer first, and then maybe I can ask two more questions.
Paul.
Okay, so in terms of the size of the waiting list, then as we entered the pandemic, the incomplete list was standing at about 35,000, and today it stands at 44,000. And you'll also recall that we had a programme of work pre-pandemic to try to eliminate the number of patients who waited over 40 weeks. And we'd got that number down to 23 patients. The number of patients who have been seen and placed on a waiting list over 40 weeks now stands at just under 11,000. So that's the kind of scale of the task that's facing us. We're currently, to be honest, Bill, modelling through how much activity we can deliver through either 5-day or 6-day working, and the impact that will have on the waiting list size and those patients waiting over 40 weeks. I would also add that we need to be careful, because the first priority that we've set as a system is to see all those patients that are referred to earlier, new patients that have been referred but not seen. And of course within there there'll be some quite significant conversion rates which will increase the number of patients on the waiting list. My initial estimates, but you know, the business information team, Nikki and Rebecca and her colleagues are working it through for me at the moment. My initial estimates are that it would take between 2.5 and 3 years on that basis to get back to where we were pre-pandemic.
Okay, Richard.
Thanks, David. So this kind of underlines one of the concerns I've got. So I fully appreciate the complexity of what we are trying to do here, and I think the paper articulates that properly. And it's good that we've got a little bit more time to make a proper plan, given the current situation. But I'm really concerned that we run from managing the COVID crisis into managing a waiting list crisis, and we're still not doing the things that we should be doing structurally to improve our situation from a performance and financial perspective. So that's a concern, and I've got two specific points to maybe help address it. One is, how can we make sure that we really dedicate management time on developing a plan which does not only manage the crisis, does an element of recovery, but also looks at fundamentally improving, based on implementing our clinical services strategy and the 10 initiatives we had around improving based on the lessons learned in COVID. How do we dedicate management time to that, whatever happens? So that's my first question. The second one is, the problem that we've seen all along, if I state it really kind of bluntly, we've essentially lost a year because of the crisis. It's all very understandable, but because of it, we've not really delivered on our PEP completely. Everything we've done was based on things we started last year. We've not developed new ideas of becoming more efficient, and we've not been able to truly make steps in implementing our clinical services strategy. The drivers of our cost, we've got a relatively clear set of controls in place in terms of managing the cost as it is, but we're not fundamentally changing the drivers of our cost. And that, in my mind, needs to come from a number of things, but one of the important drivers is how we evolve our service distribution over the sites. The evolution really of how we distribute our services over the sites, which is partially a consequence of restoration and partially a consequence of implementing our clinical services strategy. This piece of work, to me, is a very important piece that, as a board, we need to see in the timeline in the next few weeks, months. which we really need to discuss, because one, then we're back to the waiting list topic, which clearly is really important and we need to address it. But secondly, we need to look at how we structurally improve the situation such that we also work on the longer term performance and financial performance. So I'd like to see something like a deliverable related to how we evolve our service distribution over the sites, given those different drivers of it, and have that discussion in the board so that we can start working on fundamental transformation.
Yep, really good points there. I've got Matthew.
Yeah, thanks, Chair, and thanks, Richard. Your points are absolutely well made, and I think one of the things I'll perhaps ask Paul to do in a moment is just really make that link, I think, between the clinical services strategy, direction of travel to boost elective surgery on the Alex site, and the Kidderminster site, which is already touched on. But we need, and we discussed this only yesterday, the connection between our clinical services strategy implementation and the approach to addressing a restoration plan really needs to be brought together in a coherent picture, not least because we are actively discussing these points with teams of surgeons, the theatre team. We need to consider them as part of our business case development for the re-provision of theatres at the Alex. And Paul and colleagues are involved in discussions with the surgeons about these very points, because unless we get our surgical teams, and I see Vicky's hand's gone up, rightly, the surgical nursing component of this is important. So Paul, do you want to just share the reflections, outline reflections from the conversation with surgeons and Vicky? I know that you want to contribute as well around the nursing side, but Richard, absolutely, that's what we're working on. And I'm hoping that our board development session next week can take us a bit further in those discussions. So Paul, do you want to summarise, if that's all right, Chair?
Yes, but
yeah, sure. Thanks, Matthew. So in terms of the linking the two, we were very clear as a board, weren't we, in terms of the clinical service strategy, that we were moving towards the kind of hot and cold split, but at the same time the board was absolutely clear that we would be maintaining two emergency departments, one at the Alex site and one at the Worcester. And the work that's being done at the moment is how to deliver that move towards a colder site whilst maintaining that emergency department and managing the undifferentiated take, particularly on the Alex site. The plans that we're developing, that I referred to earlier, would see the majority of elective surgery for the trust being undertaken at the Alex and Kidderminster, and really ramping those services up. There are clearly some surgery that we cannot move off the Worcester site, particularly around vascular and the more complex airway surgical interventions, but they are relatively small compared to the overall number. I think the other thing I'd point out is that if we look at the vast majority of the waiting list, it is actually day cases, which is why we're wanting to establish this new and enlarged multi-specialty day case unit on the Alex to maximise throughput and capacity there, as well as fully utilising the theatres and the Ward 1 provision at Kidderminster, so that we can drive through those numbers. So that aligns the kind of board overall strategy of maintaining two-site emergency department provision, but at the same time as moving to the Worcester site being a more hot or emergency focused, with the Alex and Kidderminster having the main focus to elective. The other thing that we're looking at as part of that is going through all of the the volume of activity that we do need to deliver. And I must add, as I said earlier, the caution around seeing all these patients that have been referred and not seen, and the conversion rates which we're working through. But notwithstanding that, we are not going to be going back to a historical position of this is my theatre session. We will be moving to a specialty-based allocation of theatre resource aligned to the size of the waiting list and the prioritisation of the patients between category 2, 3 and routine on those lists. So I take your point, Richard, that don't jump from a crisis of a pandemic to a crisis of a waiting list. But I think the only way to actually manage down that waiting list and return to pre-pandemic, or preferably better than pre-pandemic levels, is actually reconfiguring the way we use the physical resources on our sites and working closely with our staff. But it's also reconfiguring the way we allocate those resources between services, not just between sites. And I think they will lead to some of the points you're making. But I also accept that, yes, that we, as part of this, it also needs to demonstrate whatever the financial regime is that we are going to face after Q1, Q2 next year, that this supports us driving down the cost base, not simply containing what is in reality still a 80 million deficit, albeit we will end up in a break-even position this year. And that figure obviously doesn't take account of any automatic pay rise or CNST costs running into 21-22. Does that help?
I'm very conscious of that. This is an important conversation that we need to have. We have got the opportunity of a specific development session to go through this in a bit more detail. But it seems to me, so bear that in mind. We're going to have to, certainly as far as the rest of the agenda is going to move through it pretty rapidly if people want to continue with this conversation. And it seems to me this is quite an important precursor conversation that we need to have. So I'm going to shorten the rest of the agenda, but we're going to spend a bit more time on this. It seems to me in these circumstances, when faced with a whole load of complexity, a few simple rules would be really helpful for the board to set out, I think, and perhaps we might think about that as far as the development session, to enable people to get on and do the things that are important. So anyway, I've got a series of people who want to speak. I've got Vicky next.
Okay, Richard, thank you for your comments that you made, and you particularly referenced the high impact actions. And I think in the professional discussions that we've had with nurses and other professions, there's a lot of benefit in terms of how we practice during COVID and the efficiency that has created, and some of the responsibility that perhaps medics held on to before that have clearly been picked up by nurses, and therefore demonstrated the full benefit or the potential benefit of those clinical nurse specialist roles, as well as advanced clinical practice. So I think that the structured approach that we've got to take is making sure, as we discussed with the patient story, that we don't lose some of those positive benefits of ways of working, efficiency ways of working, and through the QIA process as we go through the restoration, that we maximise on that and make it very clear about how more efficient we're working. We had an example that came through our nursing workforce group on Tuesday, which demonstrated a review undertaken by an advanced nurse practitioner who made a proposal in terms of skill mix that actually within the same cost envelope increased the efficiency of clinical facing advanced clinical practitioners. And that's absolutely key, that we maximise those in every single example. So I think there's lots to do, but a very structured way that we need to progress that.
Okay. Graham James I've got next. Graham, welcome. I understand you're here on behalf of Mike Ellison. Welcome, Graham.
Oh, thank you. I've been hiding in the background. So Richard, I mean, you make some very good points. I think we see this as an opportunity. So we're not going back to where we were in terms of using the same principles that we were and the same practices. So, for example, moving forward, although we have a time-based waiting list, so these are all on time targets, the focus going forward, certainly in this initial period, is on, there is an agreed prioritisation framework agreed across our system, and it's a nationally based framework, so that patients will be prioritised on clinical need and urgency rather than necessarily time on a waiting list. So it gives us the opportunity to focus on those who are really at risk at the moment and make sure we put in adequate resource across our system to manage those patients more effectively. So when it comes to things like theatres for surgery, then the priorities will clearly be those patients who are most in need in terms of cancer surgery. Then the more elective planned surgery, things like joint replacements, we are looking at using other sectors to help to support that. And this is a system approach. This is with our commissioners, not us just as a provider. They're looking at how best we can use the resource across the system to deliver for these patients. So there's lots of opportunities to change the way we do things. Also, it's not been mentioned, is our collaborative working with other partners, provider partners across the region. Paul's been doing some work recently, particularly with Birmingham, haven't you, Paul, in terms of looking at some of the things that relationships we've been trying to build. Birmingham have come to us and want to start building that, because there's recognition that this is not just a local issue. There's recognition that for some of the services we need to do this on a region-wide basis for the benefit of our patients. And there's also the change in the referral patterns, so that there's less routine referrals coming in and more advice and guidance requests, which will then hopefully reduce what's coming in, the demand on the service at the front end, which will give us opportunity to therefore catch up in terms of seeing the referrals that have already been in. So lots of opportunities, Richard, and it's having those principles, as I think Sir David just said, in terms of how we approach this. But it is more on a clinical need basis now than a time waiting list basis, and I think that's going to be accepted across the system.
Thanks, Ren. Okay, Julie.
Thank you. I welcome what Graham's just said, but back to Paul, I'm really pleased about the focus on day surgery. But it's a different question in people's heads about, can this patient be a day case? It should be, why isn't this patient a day case? Why does it need to be an inpatient? And also to look at the pre and post-op optimization that can be done in the community, so you can shorten length of stay. There's day surgery and there's more radical day surgery, and I hope we're looking at the latter. I don't necessarily want you to give me a long answer, but I just assume that's what we're doing, because it's advanced heck of a long way since it was when it was first introduced, and there's a lot more we can do that way.
Yeah, and it's both ends as well, Julie, as I know you'd push me on. It's not only that in the community prior to surgery, it's also ensuring that we've got the best immediate post-op recovery, whether it be inpatients or day cases, to make sure that that patients are discharged as rapidly but as safely as possible. The other thing that we're looking at is there are I'm not saying it's huge numbers, but it is still a factor where we have patients who are undergoing day case surgery but stay overnight for social reasons, and we're working with community colleagues to avoid that happening, so that those patients are not remaining in an acute environment which is wholly unsuitable for them. So we're looking at readmission optimisation and post-operative optimisation, and some of the services such as the colorectal service, they really do have a highly efficient and effective post-op service that minimises length of stay. And in terms of the day case, I agree with what you've said, and that is we have been operating I don't like the term, but a star chamber for the last 5 weeks, which has been challenging any proposals for why surgery needs to be undertaken on the Worcester site, why it can't be undertaken at Kidderminster on a day case basis, and that has seen some shifts to Kidderminster for those surgical conditions.
Okay, Julie, do you want to come back?
Well, no, it's just there's some very good models about having virtual post-op wards and things where people are discharged, because I understand if people are living alone it is difficult, but there are models around where people don't stay in overnight, don't stay in for extended length of stays, and it ties into the point you made before about working in partnership with other organisations. We have to do far more of that, because the backlog of patients, we can't just let it run on for however. And I'm pleased with Graham said if it's going to be on critical priorities, but we still have to work far faster and more efficiently than we did. And we needed to do that anyway, never mind because of the backlog. So there are models that would help with this, but I think Paul's looking at them for what he said, but I'm happy to spend more time talking to you about that, Paul, if you want.
Okay, thank you. Joe,
yeah, that would help, Julie.
Can we just move on, Paul, please? Joe, do you want to kind of sum it up, please?
Well, I wasn't sure, was Mark wanting to come and share, or...
I've lost him. Mark, are you there?
You're on mute, Mark. You're on mute.
I'll pick it up in the development session, Chairman. Move on.
Thanks. Okay, Joe.
Okay, so, well, just to summarise, thank you first of all, Richard, for raising the point, because I think this is really where we want to get to, because we need to make sure we've got the restoration work in a frame that actually enables us to challenge clinical services strategy work and the HIC work as well, and we're washing all that through the divisions at the moment, and actually, you know, looking at it in a different lens and trying to prioritise what we need to be working at, and the site strategy is clearly one of those key enablers. So I think it would be a really good discussion to take through, and we're also then looking at high impact changes, asking ourselves a question, are there others? And I think Vicky referenced, you know, a couple of examples that we need to replace with the ones we've already done, and which ones do we need to accelerate, and that they're conversations that we're going to have over the next few weeks. So absolutely spot on in terms of where we need to go, and hopefully we can bring something back in the future soon.
Right then. Thanks for all of that. It was an attempt, I think, to bring three things together which are important to be seen together: the annual planning process, the restoration, recovery, and the medium-term financial position. And I do think that we need to get underneath some of these things in a bit more detail at the development session. And I think that from the board perspective anyway, to give clarity to what we're doing going forward, we need a series of simple rules and principles on which we need to operate. I'll give you 2 or 3 as a starter, but I think these are the kinds of things. So, for example, we don't approve business cases unless we've got a source and application of fund. You know, simple as that. You know, we don't do it. Secondly, every extra pound we get in, we make sure, as extra money, we make sure a maximum amount of that is used to pay down the deficit, so that we improve our efficiency to enable that to happen. Thirdly, when we say we're going to significantly increase the amount of elective activity at Kidderminster and the Alex, and create much more of an emergency hospital at Worcester, we mean it and we do it. And there's no kind of, you know, other way around it. So they're the sorts of things, very clear, I think, principles that we need to identify to make sure we, in the complexity of the work that people have to do, there's clarity from the board about what's expected. So I'm looking forward to that discussion. I think we'll get it right. Thank you. So we note the change in timetable and approach the annual planning for 21-22. And we endorse the direction of travel and approach proposed. And just to give Paul a bit of morale boosting support on all of this, whatever plan you come up with, it won't be good enough. You know, there's a huge well that we all know of ill health and problems out there in the community amongst our patients and amongst the population, and we need to, as fast and as safely as we can, get that work. And if it, whether it means working with the private sector, whether it means radically changing the way we do things, we need to do it. But at the same time, we need to recognise the recovery and restoration that our people need as well. So whilst we're impatient to make changes happen, we need to make sure that our people, our staff, are supported to enable that to happen. So let's move on then. The integrated performance report, I don't really want to make a great fuss about this, in the sense of most of it I guess we already know from the previous conversations, but if there are 2 or 3 things I think that people feel that we need to highlight, I think that would be appreciated. So, is Vicky going to present this?
Yeah, thank you, Chair. I think you're absolutely right. So this is the integrated performance report for the period of January, when we were in an alert level 5, and much of what we've talked about over the past couple of hours is pretty much captured here. So as an executive, we'd identified some areas of challenge, so the impact of COVID-19 and how we've managed that through that sustained high level period of pressure throughout January, and the surge and the super surge areas, and how the operational services have had to react and be agile as we've done that, and certainly how we've kept operational grip and control as we've gone through that period through the bronze, silver and gold command incident structure. The impact into the waiting list, which we've just talked about and rehearsed before, particularly in that January period. The impact of infection prevention and control and managing across all of our hospital areas during that period, and also the health and well-being of our staff, and how important it is that we get that staff wellness offer right and put some immediate focus and support around that. And then, as we've also just described, the changing financial regime that's been in place for 2021, and how difficult that's been to manage throughout this period. The report includes some committee assurance statements from our subcommittees of the board. They're there for noting, and this report is there for noting as well, Chair, unless anyone else wishes to put anything else up.
Thanks very much, Vicky. Any questions or comments that people want to make about the report? Okay, I mean, obviously I don't want to stop people doing this, but a number of the issues we've already covered. But Colin.
Thanks, Chairman. A very specific point, but one that I think is worth raising. In the section of the report that relates to maternity, we've got an assurance level at 6, which is quite high. It's shown as a green, and I wondered if we need to put that in the context of the CQC report, because clearly, at face value at least, they may appear to contradict.
I think if I could respond, Chair, because I think this is really important, Colin, as we've been working through with the levels of assurance, that we're explicit upon what we're basing those levels of assurance on. And I think the systems and processes that are there, that are described in some of the performance issues, then the level of assurance that has been put forward is on the basis of those systems and processes in place. It's not directly relating to the CQC report, and the CQC report we will come on to, but that isn't an issue that we would represent a level of assurance, but it certainly provides the context around some of the performance issues and whether they are related, and in this case they're not, in terms of related to staffing concerns, so it's disconnected to the CQC report.
I do think there's an issue here, though, and I don't know if this is the right place to raise it, but I will anyway. Which is the CQC report, for me as chair of the board, came as a bit of a surprise. It wasn't something that our processes alerted us to before it actually happened. Now that may be because I'm the chairman, and not specifically engaged in it. But I don't know whether other board members felt that there was something brewing in maternity that was going to do this, but I doubt whether they did, to be honest. And I just wonder whether there's a bit of work to be done to think about what it was about that kind of not quite blindsided the board, but certainly became a surprise when it first happened. I don't know whether you want to respond to that, Matthew.
I mean, if I just start with the comment back, I mean, I think there are, and I had this discussion with Mark recently, because I think there are some reflections both at the divisional team and for myself as the maternity safety champion that looks back at the period of time preceding some of the issues that were building up around staffing, because we need to remember that this was in the context of COVID and significant gaps in terms of absences due to COVID over and above the vacancies that were held at the time or that were in position. And the opportunity to give a voice to staff at every side, my reflection is that we could have made that process more robust as it led up to that period of time that had been difficult. There were walkabouts, there were safety walkabouts, there were safety huddles every day from which staff could raise concerns, but clearly we didn't do enough for the members of staff that felt they had concerns, and it's important that the divisional team, and they have been doing, provide every opportunity in different ways to fit in with both the community team, the continuity of care team, and the inpatient-based midwifery teams, as well as the other professionals. I think that's important to reflect.
Yeah. Okay, Matthew, do you want to come in?
Yes, yeah, thanks, Chair. And just to build on Vicky's points, I think I think one of the reflections also for us is the extent to which this quite significant change in the way in which midwives will be working from being allocated to either the community or to an inpatient setting, and the move to continuity of carer. That's a significant change management process that I think we will want to just reflect on how going forward the rest of that implementation is managed carefully by the Division of Women's and Children's. And I think the other point is that, of course, during the COVID last year, we have stepped down our divisional clinical and corporate divisional performance review meetings, where I ordinarily would have expected a divisional team in their key risks, part of that discussion, to have raised any risks around staffing and the combination of that in terms of its potential impact on quality. So I think that's another learning, David, that I think we certainly reflected on what to build into the restarting of our performance review meetings, which is imminent.
Okay, Anita.
Thanks, Chair. My first question has just been addressed by this debate, so thank you for that. The second one is completely unrelated. It's just but does relate to our previous discussion on the previous paper. I did notice in the IPR somewhere there was a comment about the fact that in terms of our virtual consultant-led outpatients, that we were ahead of target on the first appointments, but that we were actually under target significantly on the follow-ups. Well, given that that's something that's going to be a really important area for us going forward, I wondered if you had a view about what does that tell us? Is there something we have to change in order to make that effective? Because if we can't get follow-ups virtual, that's going to be a significant problem for us. Thanks.
Okay, who wants to take that? Paul?
Paul? Yeah. We discussed this with Paul before, and he has an answer. I don't know where he is now.
Okay. Well, let's hold that till he appears. Bill?
Thank you, Chair. I just wanted to offer more assurance to Colin that the level of assurance around the maternity paper was very carefully considered at the Quality Governance Committee. I think one of the elements that we need to remember is, although it feels quite recent, the Quality Governance, the CQC report is a historic document now, and that actually a lot of things have changed since December to now. very much under Vicky's leadership, and we scrutinise those things very carefully. I think Matthew's point around the change process that has happened in midwifery is a really important component of the disquiet felt by our nursing team. I think from the QGC's perspective, the disappointment was that whistleblowing was the origin of the need for inspection, and I think that was one of the messages we took away very strongly, that in working with our staff, we need to produce a culture where whistleblowing is unnecessary, and that we can use that our staff can use the avenues available to them to raise concerns more readily to the executive team. So it is to support Matthew and Vicky's comments, and I think the assurance level of 6 should stand.
Okay, thank you. Any other points? I mean, my guess in terms of the points I would make in terms of the report is, first of all, sepsis. It's just taking too long, isn't it, to sort this issue out? And I understand that the QGC have got a session on this coming up soon, but I still feel that we're not sufficiently organised in terms of either delivery or at least the measuring of the delivery. And secondly, the issue of urgent and emergency care in January, which we had was obviously in the organisation a real big problem. Now, my understanding it got better in February and March, but I'd appreciate a kind of comment on both of those issues, if I could. Who's going to talk to me about sepsis?
Matthew's got his hand up.
Sorry, Matthew.
Yeah, so perhaps, Chair, I mean, it refers back to my earlier comment in my Chief Executive's report about focus now back on some of those things that have been nitty-gritty, difficult issues for us to address. We've got a sepsis deep dive coming up, as you know, with Quality Governance Committee, and we as an executive team are going to focus back on exactly what it is we need to do to drive this forward now that the numbers of COVID patients and, as I said earlier, the teams are returning to their normal jobs, that we get an absolute grip on this. Certainly the 4-hour standard performance has certainly improved significantly at the Alex since January, and we continue to have some pressures on the Worcester side, which partly COVID related, but I think partly to do with Paul's earlier points about flow through the hospitals and through the system, and we're going to continue absolutely to drive that forward. I think there's no absence of focus. I think the key now is about accountability in both the urgent and emergency and the sepsis elements, which I think we now need to focus on firmly. So I see Bill's hands up. We'll probably want to respond to the sepsis point.
Thank you, Matthew. And it is to say that sepsis is absolutely in the crosswires of the Quality Governance Committee now. I think the deep dive is absolutely necessary to ensure that we are measuring the correct measurables and really understand what the barriers have been to this wicked issue that has really sat with us for months. Locally, we have lots of resource that we can turn to help develop new tools or whatever we need. So please feel that the Quality Governance Committee will hold the executive to account around the sepsis issue.
I mean, the issue, I suppose, the frustration from all of us is it does remind me a bit of the conversations we had about mortality, 18 months ago, where we increasingly, and in the end, the way we unlocked it was having someone from outside having a look at it. Now, I'm not suggesting we get to that stage yet, it may not be necessary, but nevertheless, Bill, really important that the committee gets underneath this and we get clarity about what we're doing. Okay, very good. Any other points? Okay, well, we'll note that. I think we'll spend a bit more time on this as we think about the agenda for next time, a bit more time on the performance at the next meeting, when I think we'll be clearer about the COVID position and we can start to get underneath, as Matthew says, some of these really wicked issues. As far as the committee chairs, anything to bring to our notice? Richard?
Well, we also spent a lot of time on the previous topic, so I don't want to repeat that. Maybe two things that we are going to spend more time on. One is the digital program and where exactly we are also in relation to the PASS upgrade in the coming weeks.
Yeah.
And the second thing is the estate strategy as one of the supporting strategies for the overall plan.
Yeah. Okay, Bill?
No, I think the paper is as stands. I think there were some very important things hidden amongst them. The hashtag Call Me initiative, I think something that I'd like to share with the board at a future date to really encourage our engagement with that. And I think the important developments in PALS and ensuring that we have a PALS service that's fit for purpose were two really important high points at the last meeting. But thank you.
Okay, thank you. Mark? People and Culture?
The only thing I was going to mention was to complement what Bill said about maternity. The committee looked at maternity staffing in quite some detail along with other staffing, and to say that the assurance level is appropriate based upon that, and the recruitment is quite strong in that area now. But apart from that, nothing else, Chairman. Thank you.
Okay, thank you very much. We'll note all of those. But let's move on then to the nursing and midwifery staffing report. Vicky?
Sorry, take yourself off mute. So you have before you detailed report in terms of the adult nursing normal paper that we receive at the board, and this covers the period of December and January. The maternity staffing paper that is in more detail than we've normally seen at the board is for the reasons that we've just been discussing, and the importance there is very clear and transparent the challenge of the staffing that we were faced in maternity over that period of time, which is a difference. So it was the October and November period of time, so slightly out of sync, but that will get back in line, but important for the topics that we've got on the board today. So I think importantly from the adult nursing perspective, we have gone through this in detail in both QGC with the link between staffing and obviously safety, and in people and culture regarding the system and process to ensure the rigour over the safest staffing during the challenges that we face during December and January. So that is there to note of all of the actions, and particularly the appendices to the paper, where Jackie has authored that presentation, because that outlines all of the measures that we took with the blended staffing models, which we've talked about again at committee level and previously at the board. And importantly, the staff, the support that we're going to make sure is ongoing for staff as they leave those areas that they've been allocated to, ITU and some of the ward areas, back to their normal roles, and important that we support them with the decompression from what they've been through during COVID. So it is a comprehensive report, but I make no apologies for that, because it was important that as a board you've seen all the measures and controls and processes that we have in place to make sure staff feel supported. But important to note, which is always answer the exam question for Mark, which is that there were no incidents related to staffing in that period of time that we're reporting against. So happy to take any questions.
Okay, any questions about that? It's a one hand up after you do.
Richard.
Yeah,
Richard,
it's me, David. I don't have a question. I just wanted to make a compliment. I think this is really well managed during a very difficult time, and I also wanted to compliment the flexibility of all the staff making this possible. So just wanted that note.
Thank you, Richard.
That's absolutely right. I mean, the interesting, and I agree with all of that. The only thing I'd add to that, though, is that what it doesn't say in the paper is whether we can afford any of this. And I just think in future, I'm not suggesting one should run the other at all, but I am suggesting that increasingly when we bring papers that are uni-professional, unidisciplinary, that we have an eye to the wider context in which they're working, so at least we can understand where the pressures are and where they are. That's the only point I'd make.
Yeah, and I think, David, if I can just respond on that, because I think the flexibility that staff have shown is amazing over this period of time. And as I've said at the board before, placing on record my thanks to all of the multidisciplinary team. But I think we have focused within our NWAG groups, that's the nursing workforce group, with other disciplines as well, about the rigour of what we've needed to do to keep the care as safe as it can be during COVID. The flexibility between professions is very clear, and then how we don't lose that and we maintain the focus of our controls and systems and processes to make sure that we are as efficient as we can be, related to the comments I made earlier in terms of some of the benefits that we've seen in terms of job planning and utilisation of the skills of some of those clinical nurse specialists and ACPs. So that there's a lot that we need to continue to focus on around the efficiency in workforce.
Thank you, Vicky. Okay, let's. So we note we're assured that that is in good place. It's been through the People and Culture Committee and QGC, as you say. Thanks for that, Vicky. Shall we move on then to the CQC inspection report, maternity? We have obviously covered some of this before in the conversation, but also at the previous meeting. But go on.
No, I mean, I wasn't. The main points really, we have picked up quite a lot about it, and whilst it's disappointing that the outcome of the CQC focused inspection, which was intended to look at safety and well-led, the outcome of that focused inspection was that we have gone down for the Women and Children's division, down one from good for well-led to requires improvement, which then overall impacts and takes that division down from good to requires improvement. So the team themselves are very disappointed, but I do want to place on record my thanks to the team. This is a leadership team at the Women and Children's division who are determined to pick up and address all of the points that are made explicitly in this report, the CQC report, and you'll see the response report that has now gone back to CQC. The deadline for our response was by the 19th. That was sent yesterday, and it's important now that we support the divisional team and the staff in taking things forward. But I think some of the gaps in terms of communication that I was referencing before, and Matthew's point about the continuity of care team, there are lessons to learn from actually how we embed change, take staff with us so that they understand those changes and can actually understand how they work with each other. So I'm using the example of the community team and the continuity of care team. And in the many discussions that we've had with staff, we have explored that, and there is a lot that can be done to support staff going forward. I think it's really important for the board to note that on the day of the inspection there were no safety concerns, and that's important in reassuring our mums and their families, and important that we reiterate that to staff, and important that they gain confidence in how they will raise concerns with us. And so the division have got lots of examples of how they're going to continue to have different approaches to communication, listening to staff, really important, and importantly, as should always happen, feeding back to the staff about the actions that we are taking. But as the maternity safety champion, continuing the walkabouts across the maternity floor, and David, you kindly accompanied me on one of those visits, the staff are very open about discussing their concerns and any issues, and it's maximising on that and making sure that they understand all of the range of actions that we take in response to that. But I'll pause there because I think the paper speaks for itself, but happy to take any questions.
Thanks. Anita.
Thanks, Chair. I mean, Vicky, thank you for the paper, and I think, you know, actually, yeah, it was disappointing simply because actually, as you say, yeah, in terms of the CQC's decision, because actually, as you say, when it came to safety and things, it sounds awful to say it, but it wasn't as bad as all that sort of thing. But so I think you know that's the one thing. I think the thing that I found most concerning, and I think it picks up on a comment that Bill made earlier, is the fact that apparently there were concerns raised initially in October, and that people felt the need to go to you know, to start whistleblowing, when actually our Freedom to Speak Up Guardian is a matron in maternity. And it doesn't, you know, from what I know of the culture of maternity, they, as you said just now, they come over as a team that are not backward at coming forward and at speaking up. So that the fact that happened in that team, it seems not weird, but just very, very disappointing. And I wondered whether, in terms of the actions, and I can see the action plan, and there's lots of very practical things in here. Practically, what are we doing to get under the skin of what actually happened? Why was that possible? And what are we going to do to address that cultural problem? Because exactly as Bill says, we don't want whistleblowing. We want them to raise it, if not to their own managers. You know, the Freedom to Speak Up Guardian was just right there, and it seems very, very frustrating that that's what happened.
Yes, indeed, and I think the importance is that we support the teams to have an understanding of what actions are taken each and every day when they escalate concerns. There was some comment in the report that you will have picked up about incident reporting and some cultural issues about actually feeling that it was up to managers to put in those DATEXs. And it's really important that we have very open discussions to support them to understand their professional obligations in raising concerns when they have them, and then making sure that we pick up and support them with some of the points that Matthew made about continuity of care. It was very clear that actually they didn't understand the full extent of how that continuity of care team would work, and the flexibility that gave the teams on the inpatient units, the fact that you could pull from those continuity of care teams into support the staffing, which are actions that were undertaken. So there's ongoing discussions. I think to your first point, it's very difficult when those whistleblowing concerns that were raised remain anonymous, and we've obviously would love to speak to the individuals directly to understand further what else they would have liked to have had in place. But we can continue the open discussions, and certainly when I've had these sessions with the community midwives, we had really good attendance because they wanted to physically meet. We did that, clearly socially distanced, but they were very open, and they equally gave each other challenge about the positive things that can happen and we can put in place. So I think lots of actions to undertake, continual listening, but I think the divisional team are one that are clearly committed, as are Matthew and myself, in terms of making sure we give every opportunity for staff to share their concerns and address those.
Okay. Any other points? No. Right, well, this was I'll sum up now, just so that you know. This was a kind of the way I would describe this is that we had a problem, or there was a problem. We recognised it, but we recognised it too late. But then once we did recognise the problem, we took a lot of action to go forward very quickly to make it happen, which is a good outcome if you look at what we've started to do. But fundamentally, underneath all of this, we had a group of midwives who, first of all, felt that there were problems that they couldn't themselves do anything about, and that they found a management system which was unresponsive to their initial views. Now, we can debate around the corner, but that fundamentally was at the heart of all of this. And this is an issue for the organisation as a whole, not just. If you look at I know we're going to spend some time on. You look at the staff survey, you can see how people feel that either they haven't got the power themselves to make change happen, and that they've got an unresponsive management system there for them. So I think this is really, incredibly helpful for us in the sense it focuses our attention on the really important things we need to take our organisation forward. Now, I'm not suggesting we discuss this now, but it's something I'd like the People and Culture Committee to give a bit of a thought to, and for us to think generally about how we're going to take our organisation to the next stage so that we reduce the opportunities for this to happen. And then
David, could I just jump in there slightly, just to pick up on the first point that you made, because I think it's really important that the team did know in terms of the staff absences and the challenges that was providing. and made sure that we met the minimum staffing levels. That's really important for us as a board to note. It was actually the feedback to staff that I believe is where we fell down, in that we didn't share all of the full actions that were being taken to make sure that we met those minimum staffing levels. And that's the issue of communication, as with any leadership challenge, to make sure you are always feeding back and explaining at every single opportunity. So, we did recognise it. It was picked up. There was clear escalation, as in our policy, and we met that each time. But did we share enough about the full actions and how we were doing that? No, we didn't.
Well, I'll allow you that one, Vicky, on the basis that I was summing up and you've interrupted me. Because that is probably the last time you'll make an intervention at this board. But no, that's a good. Sorry, it's a good point that you made. My issue was moving up the system. We were unaware. We were unaware that there was all this going on underneath there. People were not getting satisfaction. That was the point I was trying to make. And then the final point that I would make is around this massive management of change program that's going on in maternity at the moment, which is often for us not very visible. This is a massive transformation going on about the way in which we support mothers and families through their pregnancy, and the way that we intervene and all the rest of it. It's really one of the biggest changes going on in our hospital in terms of transformation, and it is not widely understood. It's not even widely understood, I discovered, in the midwifery profession. But at some stage, I think it would be really helpful for the board to be exposed to the scale and nature of this transformational change, to assure ourselves that we're putting the right amount of resource and support to enable it to happen. And then the final point, just a small point, one of the things about CQC reports that wind me, there are loads of things that wind me up about the report, but one of them is the way they refer to midwives and managers. And basically the midwives are all marvellous and the managers are all, not very responsive. The point I would make is that all these people they call managers are actually midwives. Very professionally led organisation. And you get this impression that managers are walking around with clipboards, kind of, saying no to these. But actually, there's a very ongoing professional debate and discussion about this to make it happen. And sometimes it doesn't come out in the organisation, because one thing you can say about our Women and Children's division, it is very, very strongly clinically led. Very strongly clinical, probably the most strongly. So I just want to make that point about the way we do things. Anyway, that's enough of all of that. Thank you very much for that. So we received the report, and we note the actions that have been taken, and I'm pleased to see that we've got our action plan into CQC at the earliest opportunity, so we can make the changes that we need. Thanks very much for that. Okay. Let's move on then to going concern, Chief Finance Officer.
Thank you, Chairman. This is hopefully quite a straightforward paper. We have taken it through both Finance and Performance Committee, Trust Management Exec, but also the Audit and Assurance Committee. Effectively, it's just requesting the board endorsement that we are operating on an ongoing concern basis, which we are according to our colleagues at NHSEI and the Department of Health and Social Security. So it's really just for the board to endorse the paper, Chairman, in simple terms. One thing to note, I should just want to point out, is in all likelihood, given the challenges we've had in January and February with activity, that our finance, our monetary position being forecast into the end of the year, and I've just received February's position, is that we're likely to probably hit break even this year, which is a positive statement, but obviously it is due to the fact that we received a significant amount of funding in the year. But just a point to note.
Okay, thanks, Robert. Any comments on all this? Anita, do you want to say anything from the Audit Committee's report position?
Just to say, Chair, that as Robert says, we did have a look at this paper on Tuesday or whenever it was. We had our meeting this week, and we were comfortable with recommending that we endorse this.
Fine. And Richard from the Finance Performance Committee?
He's gone.
Oh, he's gone. Okay, yeah, okay. Colin, were you at the meeting?
Yes, Chair. Sorry about the delay. Yes, I was there, and as with the Audit and Assurance Committee, we looked at it and recommended it for endorsement by the board.
Okay. Fine. So we endorse the Chief Finance Officer's report. Thank you. Right, Trust Management Executive.
Chair, nothing to report. Take the paper as read.
Okay. Okay, we have no other business, so I'll bring the meeting to a close. Thank you very much for the contribution. I'm sorry I went slightly over, but there were some really quite important points that we had to take in all of that. So that's the end of the meeting. Thank you very much. Bye.
Rebecca, do you want to stay on the line so we can organise when we're going to meet?
Yes, that's absolutely fine, no problem. Bear with me.